Hemoglobin can be adult hemoglobin, which is called as hemoglobin A, fetal hemoglobin, that is hemoglobin F, or there is a minor part of hemoglobin also called as hemoglobin A2. In a normal adult, the blood will contain 96% of the hemoglobin A, alpha 2 beta 2, and 3.5% of hemoglobin A2, and small amounts of fetal hemoglobin. Hemoglobinopathies. They are classified into qualitative disorders and quantitative disorders. In qualitative disorders, there is structural abnormality in the synthesis of hemoglobin, and they are called as sickle cell syndromes. In quantitative disorders, there will be quantitative decreased globin chain synthesis. These are categorized as thalassemias. Sickle syndromes are autosomal recessive disorders. Due to the presence of sickle hemoglobin in the red blood cells, the red cells with HbS will develop sickling when they are exposed to low oxygen tension. Sickle syndromes have the highest frequency in black race people and in Central Africans where falciparum malaria is endemic. This can be in three different forms: heterozygous state, that is sickle cell trait; homozygous state, that is sickle cell anemia; and double heterozygous state, that is sickle cell C disease or sickle D disease. Coming to sickle cell trait, heterozygous state is benign. In this, only one abnormal gene is inherited from the parent. These patients have no anemia and have normal appearance of red cells. In hypoxic crisis, this sickle cell crisis will develop. Sickle cell anemia or homozygous state. In this, abnormal gene is inherited from each parent. Sickle cell trait, only one from one parent. Here, abnormal gene is inherited from each parent. So, sickle cell anemia is a severe disorder associated with protein clinical manifestations and decreased life expectancy. The hemoglobin consists of the genes are present on chromosome 11, beta globin gene. There will be a mutation in this chromosome 11, which is a single point mutation at the sixth position of the beta globin chain. You can call it as missense mutation, okay, or point mutation. As a result of this missense mutation in the sixth position of the beta globin chain, there will be a substitution of valine residue for a glutamic residue. That is, glutamin is replaced by valine. As a result, hemoglobin S or sickle hemoglobin will be formed instead of hemoglobin A. The change in amino acid sequence will cause hemoglobin molecules to crystallize when oxygen levels are low in the blood. As a result, RBCs will get sickled and get stuck in the small blood vessels. Deoxygenation of hemoglobin S containing red blood cells or results in deoxygenated hemoglobin S or sickle hemoglobin. Polymerization of deoxygenated HbS. There will be elongated rod-like polymers, and these elongated fibers will align and form aggregates, thereby distorting the red cell into classic sickle shape, which is called as sickling. Sickle cells will express higher than the normal levels of adhesion molecules, and they are abnormally sticky. There will be vaso-occlusion of the microcirculation, especially in the bones, lungs, spleen, and pennies. Sickling of the red cell is reversible initially with oxygenation. So, when the hemoglobin is exposed to oxygen, the sickle cells convert back to normal. HbS depolymerizes and RBC shape will normalize. But with repeated episodes of the deoxygenation and sickling, the membrane damage will occur permanently and the RBCs become irreversibly sickled. That is, they will retain their normal sickle shape even when fully oxygenated. Irreversible sickle cells have rigid, non-deformable cell membranes that leads to difficulty in passing through the splenic sinusoids. As a result, there will be splenic sequestration and followed by rapid phagocytosis, which will result in hemolysis outside the blood vessel, that is extravascular hemolysis, resulting in hemolytic anemia. With membrane damage, water comes out of the cell, resulting in intracellular dehydration, and there will be increased MCHC. So, increased MCHC is also seen in sickle cell anemias. Reversible sickle cells are responsible for vaso-occlusive symptoms, and the irreversible sickle cells are responsible for the hemolytic anemia. Hemoglobin A is converted to hemoglobin S because of the deoxygenation. The glutamic acid is replaced by valine because of the point mutations at the sixth position of beta globin gene on chromosome 11. There will be membrane changes, increased adhesiveness, increased RBC transit times in inflamed tissues, and there will be splenic sequestration. In the earlier stages, there will be microvascular occlusion. In the late stages, there will be hemolysis, congestion, and infarction of the spleen. Factors determining the rate of sickling. This can be asked for a 6 marks question or a 3 marks question. Amount of HbS and interaction with other hemoglobins. Most important factor for sickling is amount of hemoglobin S. In homozygous individuals, all the hemoglobin in red blood cells is hemoglobin S and undergoes sickling. In heterozygous conditions, only 40% of hemoglobin is HbS. Sickling does not occur because HbA, which is remaining 60% of the normal hemoglobin, has an inhibitory effect on polymerization of the HbS. Fetal hemoglobin also has inhibitory effect on sickling of the hemoglobin S. Newborns do not manifest the disease until they are 5 to 6 months of age, when the amount of hemoglobin F in the cells falls close to the adult level. So, fe- fetal hemoglobin is present up to 6 months. So, there will not be any sickling seen in these patients or children. After the 6 months, they may show the symptoms of sickle cell anemia. Hemoglobin concentration of the cell, which is also called as mean corpuscular hemoglobin concentration, which is raised, will affect the polymerization to a great extent. So, greater the MCHC, greater will be the sickling. Intracellular dehydration. Intracellular dehydration increases the MCHC, which will facilitate the sickling. Conditions that decrease MCHC. When sickle cell anemia occurs with alpha thalassemia, there will be reduced sickling. Decrease in pH, that is acidosis, reduces the oxygen affinity of the hemoglobin. Thereby, there will be increasing the fraction of deoxygenated hemoglobin S, which will facilitate the sickling. The length of the time red cell exposure to low oxygen tension, that is, the organs having slow or sluggish circulation like bone and spleen, have an increased risk of sickling. Clinical features of sickle cell syndromes. There will be anemia and vaso-occlusive phenomena. Anemia. Irreversible sickle cells have rigid, non-deformable cell membranes that will lead to difficulty in passing the splenic sinusoids. There will be sequestration and rapid phagocytosis. Anemia is associated with jaundice and reticulocytosis. Vaso-occlusive phenomena. Reversible sickle cells express the higher than the normal levels of adhesion molecules, and they are abnormally sticky. So results in occlusion of the microcirculation, especially bones, lungs, spleen, and penis. Vaso-occlusive symptoms are the most common manifestations of sickle cell anemia. In the bone, there will be dactylitis, that is inflammation of the bones of the hands and feet, also called as hand-foot syndrome. There is increased chances of Salmonella osteomyelitis. There may be increased chances for avascular necrosis of femoral head. Fish mouth appearance of the vertebra due to occlusion of vertebral arteries is seen. There will be prominent cheekbones and there is crew-cut appearance or hair and appearance of the skull. Acute chest syndrome is characterized by cough, fever, and chest pain. There may be seizures or stroke because of this sickle cell anemia, and leg ulcers will be seen. Stagnation in the corpora cavernosa leading to priapism. Spleen in the initial stages, there will be splenomegaly due to congestion and trapping of the red cells in the vascular sinusoids. As a result, gamma antibodies will be formed. Gamma antibodies can be asked for a 3 marks question, or in the MCQs they can ask you. Gamma antibodies consist of foci of fibrosis having iron or calcium salts deposited in connective tissue. Prolonged hypoxia and infarction can lead to autosplenectomy, which increases the susceptibility to infection with capsulated organisms like Haemophilus influenza, pneumococcus. In sickle cell syndromes, you will see two types of crisis. One is vaso-occlusive crisis and the other is aplastic crisis. Aplastic crisis occurs from the infection of red cell progenitors by parvovirus B19, which will cause a transient cessation of the arthropoiesis and a sudden worsening of the anemia. So, aplastic crisis is because of the parvovirus B19 infection in the red cell progenitors, various conditions that are seen in a case of sickle cell anemia. There may be stroke or retinopathy, anemia, aplastic crisis, infections, acute chest pain, acute abdominal pain, splenic atrophy, hematuria, priapism, chronic leg ulcers, ischemic necrosis or avascular necrosis of bone, peripheral smear picture showing the sickle cells. You can appreciate the target cells also. Sickling test. It is a method where a sample of venous blood or capillary blood is collected and the venous blood from the arm is collected. Capillary blood from the fingertips or earlobes and in infants from the heel of the foot can also be used. Mixing this blood with a reducing agent like sodium metabisulfate will induce sickling in susceptible cells. 1% sodium metabisulfate is helpful in inducing the sickling in susceptible cells as it is a reducing agent. This test is very simple and quick, used to identify the presence of hemoglobin S. Positive sickling test associated with a normal hemoglobin is likely to indicate a patient with sickle cell trait. Screening for sickle cell anemia. Sickling and solubility tests are used for screening. Hemoglobin electrophoresis. Hemoglobin S moves slowly towards the anode, whereas the hemoglobin A will move faster towards anode. This will helpful in identifying a sickle cell trait and sickle cell anemia. Patients with hemoglobin S are relatively protected against falciparum malaria. This can be asked in the 3 marks question or MCQs or in the practicals viva. The two reasons are: first one, malarial parasites consumes oxygen and decrease intracellular pH. So acidosis will promote sickling in these red cells. And these distorted red blood cells are cleared rapidly by the phagocytosis in the spleen and liver, and this will result in parasitic load reduced or parasite load is down as it is removed there and then. The second reason is normally malarial parasite forms membrane knobs containing a protein PFEMP1, that is Plasmodium falciparum EMP1. These membrane knobs help in adhesion of infected red cells to endothelium. Sickling impairs the formation of membrane knobs. That's why the patients with hemoglobin S are relatively protected against the falciparum malaria. Conditions that provide protection against malaria are: first one is G6PD, that is glucose 6 phosphate dehydrogenase deficiency. Second is alpha and beta thalassemias. Third is sickle cell disease. Fourth is absence of Duffy antigen. Fifth is pyruvate kinase deficiency. And sixth is HPC.